very lucky to have Dr. Sami El-Dalati to talk about his experience developing a multidisciplinary endocarditis team. Dr. El-Dalati joins us via the University of Kentucky, where he is assistant professor of infectious diseases. He completed his medical school at the Ohio State University and then did his med-peds residency, as well as his ID fellowship at the University of Michigan, where he developed this team to great acclaim and interest. And then he brought that to the University of Kentucky, where he is currently director of the Multidisciplinary Endocarditis program. Thank you so much, Sami, for coming to give this talk, and the floor is yours.
Thank you. I really appreciate the opportunity to talk with you guys, and very generous to say so much acclaim. It's very kind of you. I appreciate you throwing the V in front of Ohio State too. So yeah, I'm gonna get started. The title of my talk is The Importance of Being Earnest, Implementation and Outcomes of a Multidisciplinary Endocarditis Team. And what I like to do when I talk about the experience that I had starting this is to kind of tell it as a narrative. You know, obviously I'll focus on the data and the outcomes, but it's really a process getting something like this off the ground. And so I try to highlight some of the obstacles that we faced along the way. So with that, I'll go ahead and start. So I have no disclosures. So our objectives for
Dr.
today.
Dr. El-Dalati, your screen right now, we just see the PowerPoint, like the view of the slides, but I think we're not in the presenter mode.
For that, let me try.
So we see the disclosure slide, but we kind of still see the slide like the organizer on the left.
Okay, try this again. How's that?
Well, we still see we still see the slides on the left, but that's fine as long as it scrolls through, I think.
Do you have two screens?
I do, yeah.
So it might be sharing the wrong. Sometimes it does that with two screens. It presents the other.
Or you need to go to slideshow. Are you in slideshow?
Here, I think this will do it.
Perfect.
Yeah,
Thank you.
Sorry about that. All right, so no disclosures. Yeah, so the objectives for today are to talk about the University of Michigan endocarditis outcomes prior to starting a multidisciplinary team, and then highlight the improvement in mortality and other clinical outcomes that were associated with starting such a group. And then I'd like to talk a little bit about some of the research opportunities that go along with these teams. So I'd like to start with a case that was sort of typical of what the experience was like for patients prior to us having an endocarditis team, and this may resonate with some of you as well. So this was a patient when I was a resident. He's a 40-year-old gentleman who went to an outside hospital with the chief complaint of fevers. He had a past medical history that was most pertinent for a bicuspid aortic valve, for which he'd had a mechanical aortic valve replacement about 3 years prior to presentation. And so he goes to this outside hospital in April 2017 with chest pain, fevers, nausea. He also is noted to have a cool right fourth finger. He gets a CT chest at the outside hospital, which demonstrated fluid circumferentially encasing the ascending aorta, measuring about 7 by 7 by 8 centimeters. That was concerning for hematoma, post-op changes, or abscess. So based on the findings of the CT chest, he's referred to University of Michigan and is ultimately transferred there, where he gets blood cultures ×3. He gets started on broad spectrum antibiotics, Vancomycin and Gent, and cardiac surgery is consulted. So on the second day that he's in the hospital, first full day at U of M, his blood cultures are positive for MRSA in all three sets. So cardiac surgery is consulted and recommend repeating a CT of the aorta to further characterize this fluid collection. And their concern is that they're not sure if this is an infection around his graft or could it be related to some of the surgical glue material that they use with their aortic surgery. And so they're trying to clarify this. He also gets a TEE while he's inpatient, which demonstrates the aortic root graft with surrounding soft tissue density and liquid density concerning for a possible anastomotic leak or paraprosthetic infection. There's no flow visualized, no clear vegetation on TEE. So ID is consulted. They're very concerned for that this patient has MRSA aortic valve endocarditis, and that surgical source control will be the most important part of treating this infection. And without it, he may have a very high morbidity and mortality. And then what you see kind of play out in the chart is this back and forth between infectious diseases and cardiac surgery. And so ID is saying if the surgical option is going to happen, it really should happen sooner rather than later. Cardiac surgery comes back with, well, the fluid doesn't look infectious on the CT, and surgery for redo AVR with a prior Bentall procedure has very high morbidity and mortality. So they want outside operative report. ID again, just patients persistently bacteremic, very concerned for infection. You see cardiac surgery asking for a PET scan. ID, so you just see this back and forth, eventually getting to the point where surgery asks for fluid sampling of the collection. And it gets to the point as well where the ID provider is saying, I'm not sure this is a survivable infection without source control. And so the patient, 9 days after presentation, gets sampling of the periaortic fluid, which ends up growing MRSA as well. Unfortunately, while all of this is going on, we're waiting for the cultures from that fluid collection. The patient decompensates and becomes acutely hypoxic and has hemoptysis, has to be intubated and transferred to the cardiac ICU. And unfortunately, about 2 weeks after presentation, he suffers a PEA arrest and unfortunately passes away related to this infection. And during the arrest, he's having continuous pulmonary hemorrhage with clots on suctioning. And he ends up undergoing an autopsy, which kind of confirms what everyone sort of suspected, I'm sure, from hearing the story, that he had prosthetic valve endocarditis with infection extending through the aortic annulus into the periaortic graft with the abscess formation and then essentially erosion into the right lung middle lobe, which was the cause of the pulmonary hemorrhage. He's also noted to have numerous infarcts to multiple organs and congestive heart failure and bilaterally. And so this was an actual case during my residency that was presented as an M&M for the Department of Internal Medicine. And obviously hearing that case, you can see that the patient sort of struggled in limbo between the specialists that were trying to take care of him. And so, the question that I asked myself, after hearing about this case and being involved in it, the question was, well, why did we fail? And it seemed obvious as we presented this M&M that one of the big reasons for the failure was the lack of communication between the specialists. It was never clear that the surgeon and ID doctor actually spoke to each other. There was just sort of this chart war that was waged back and forth. And so, what we were seeing was this model of care, which I think exists in most places in the United States, where you have the patient at the center and you have all the different specialists kind of working, but they're all operating kind of independently in their own silos. And so there's not always a clear plan for the patient. And so this, really seemed like a system failure. The way that the care was set up for this particular patient really wasn't designed to give him the best possible outcome. And so, what often comes up when we're having these M&Ms is, oh, well, this must be an anomaly, a one of, and that was sort of the initial question that we had asked. And so I'm going to rewind a little bit and talk a little bit about, the outcomes at the University of Michigan around the time of this case and before our team. And so, just brief background on endocarditis. There's approximately 43,000 cases per year in the US. This was from data from 1998 to 2009. The in-hospital mortality during that period was about 15 to 20%. lack of randomized control trials really complicate patient management. I added an additional slide with a study that was a little more recent, which interestingly still showed about the same number of cases per year in the US, but you'll see the in-hospital mortality has declined over time. But so what we found was about 15 to 20% or 17, kind of to split the difference, in-hospital mortality nationally for endocarditis. And as we tried to look back and see, is this an anomaly? What I found was there was really no existing registry or database of endocarditis patients at our institution. We had no sense of how our outcomes compared to national numbers or how frequently we were operating. We had the Society of Thoracic Surgeons database, which would track the patients who had surgery, but then we really didn't have any numbers for patients who were medically managed. And then one of the things that became clear was that the documentation process about surgical decision-making was also an issue at our institution. And so to start out, I did a one-year retrospective review of patients admitted to the University of Michigan with endocarditis. And we used an internal research tool using ICD-9 and 10 codes to try to identify cases. And we looked at the academic year 2014 to 2015. We had 179 patients initially that were kind of screened with the ICD codes. And then after going through the chart review, we whittled that down to 78 cases of definite endocarditis and 68 cases that had definite endocarditis and at least one indication for surgery per the American Heart Association guidelines. And we picked the group with surgical indications because we wanted to look at patients where the surgeons either were involved or should be involved. And I'm sure, as you guys are all familiar, for left-sided endocarditis, this is just a quick review of the surgical indications: valve dysfunction with heart failure, endocarditis from resistant organisms, or complicated by heart block, aortic abscess, destructive lesions, or persistent infection with bacteremia, or fever lasting greater than 5 to 7 days despite adequate therapy. And then the more relative indications related to recurrent emboli while on antibiotics, severe valve regurgitation and vegetation size over a centimeter, or just vegetation size in and of itself over a centimeter. So what we found looking at those 68 patients with definite endocarditis and surgical indications was that their overall in-hospital mortality was 29.4%. So just in reference again, 15 to 20% is that national number. So we were seeing quite a bit higher in-hospital mortality than what we would have expected. What we also found was that a quarter of those 68 patients did not have a documented cardiac surgery consult. So 15% had no consult placed, 10% had a consult placed, but then there was no corresponding documentation for that consult. And not surprisingly, the mortality for those patients was even higher at 47%. And then in the remaining sort of 51 patients, about half were managed medically. You can see they had a very high in-hospital mortality of 38% and two-year mortality of 65%. And then the remaining 25 patients were managed surgically with a much lower in-hospital mortality of 8% and lower two-year mortality of 20%. What we also saw was that the average time to consult from admission was 7 days, and then it was another 7 days from the consult to surgery. So over 2 weeks from when these patients hit the door to when they were getting the definitive management for their disease. Not surprisingly, when we tried to break down the differences between the two groups, the patients who were not offered surgery tended to be sicker. So they were more likely to be on acute renal replacement therapy, more likely to be in the ICU, have Staph aureus as their organism, more than 2 indications for surgery, and then higher STS surgical risk scores. And then the reasons for deferring surgical intervention, the most common reason was that high perioperative mortality. But what we found was that the STS risk scores were not routinely documented in notes. And so a lot of the STS risk scores we had to go back and calculate retrospectively. You'll see the second most common reason for deferring surgery was continued injection drug use. But then when we looked a little more closely at the sickest patients and the ones who did happen to get surgery and the ones who were managed medically, you can see these are small numbers, but there was a trend towards even the sickest patients, the ones who did get surgery tended to do better. So if they had higher risk scores, they were in the ICU, intubated on pressors, the few patients that did get surgery had better outcomes than the patients that were medically managed. And so our takeaway from that was, the in-hospital and 2-year mortality was clearly improved for patients who underwent surgery, and critically ill patients were often not referred for or offered surgery, but could potentially still benefit from surgical intervention. Clearly, there was room for improving communication between providers, and then there are probably some other unidentified factors that are contributing to higher mortality that maybe we didn't capture with our initial study. But the question, what we were left with was, how can we do better? Because clearly, a 30%, a close to 30% in-hospital mortality at a large tertiary care center like that was not acceptable. And so we kind of started when I say we, it was really me and one of my co-residents. And we sort of looked at it initially from a QI standpoint. And so this next slide, we did our fishbone analysis and kind of good QI model. And I won't go through all the details here, but the point of this slide is really to demonstrate all the different ways that patients can slip through the cracks when it comes to endocarditis. So starting from, most of these patients would go to an outside hospital first. You'd see a delay in diagnosis. There might not be bed availability at our hospital, so there's delays getting the patients to our hospital. They may go to the wrong service because the story is not clearly transferred from the referring physician. Then when the patients get here, there may be delayed surgical evaluation because the surgeons aren't consulted, or they're consulted, but there's not a note. And so all of these things, are contributing to increases in mortality. And so when we first came up with this, it was a little overwhelming because it would be you look at all these things and you say, well, how are we going to address all of these things? What one intervention is going to address everything? And an intervention that we found that maybe doesn't address everything, but captures a lot of these things was implementing a multidisciplinary endocarditis team. And so this was a study that was first published actually in 2009 from a French group who looked at their outcomes prior to and after implementation of an endocarditis team. So between 1991 and 2002, they had sort of the standard model of care with the different consultants seeing the patients, and found that their overall mortality at a year was 18.5%. And then in 2002, they implemented an endocarditis team that met weekly to discuss in patients with endocarditis. And they also developed an institutional protocol that they tried to follow as closely as possible. And in the 4 years after they started this team, they saw their 1-year mortality fall from that 18.5 to 8.2%, and their in-hospital mortality fell to 4%. And so the idea is here that now everybody, rather than being in their own silos, is sort of sitting down at the table and all communicating with each other to better care for the patient. And as a result, principally of this study and a couple of other European studies that came out in the 2010s, the 2015 European Society of Cardiology Endocarditis Guideline included a recommendation that large academic or tertiary care centers have these multidisciplinary teams to meet regularly to decide which patients would benefit from surgery, what antibiotics and for what duration patients should receive, what the follow-up should be, and then also participate in national or international registries so that we can continue to study this population. But unfortunately, that same recommendation was not applied to the American Heart Association guidelines, at least certainly not in this level of detail. And so as a result, there really wasn't a lot of momentum for these teams after the 2015 AHA guidelines came out. So we had found this potential intervention that could really help our patients. And so this is just a little timeline of kind of how we got the ball rolling on our process. And so December 2016 was when I first started that first chart review study. And then in September 2017, finished that data collection. November of 2017 was when we presented the M&M to the Department of Internal Medicine. And we had one of our surgeons actually come and be a discussant at the M&M. And that M&M was actually really the thing that galvanized people. I think hearing that story and seeing, a young man who really didn't have a lot of comorbidities lose his life, primarily just due to the way the system was set up, really motivated people to want to change things. And so after that M&M, we had a kind of a sit-down planning meeting with myself, a cardiac surgeon who was at the meeting, two of our cardiologists, and one of the ID faculty. And we tried to sit down and come up, with what the next steps would be. And fortunately, now I had the data from the previous, a couple of years previous, so we could share that with other departments as we set out trying to start the group. And so how we did this was, over the next several months, I presented at several of the different departments' faculty meetings. So in February, I presented at the cardiology faculty. March, I presented at both the ID and cardiac surgery faculty. And so we did that, and then sent follow-up emails, and that allowed us to recruit individual faculty from each department. And so by May of 2018, we had enough people that we felt like we could really try to get this off the ground, and we had our first meeting. That first month was mostly planning. So we worked on developing sort of a format for how we were going to present cases, developing a protocol that we would try and follow. And then in June of 2018, we started presenting our first cases. So we started, first cases were June 14th, 2018. At that time, we had 3 ID specialists, 2 cardiac surgeons, 2 cardiologists. We had a stroke neurologist, the PA from cardiac surgery who saw all of their consults. And then we had one of our ID pharmacists. Like I said, in that first month, we worked on developing an institutional protocol. And then we also created a best practice advisory in EPIC, which would encourage cardiac surgery consultation for all patients with endocarditis. So I'm not sure which EMR you guys use at UCLA, but what was really nice about EPIC was that anytime endocarditis was entered in as a patient sort of admitting diagnosis or on their hospital problem list, this advisory would fire. And I'll show it here in the next couple of slides, but it would have a list of the surgical indications and then link right to a cardiac surgery consult. So this was our protocol. The first page really talks about clinical features of endocarditis, risk factors. It has the surgical indications, which bacteria should raise suspicion for endocarditis. And then it just kind of works through, algorithmically in terms of what's your initial eval, when do you get a TTE, when do you go to TEE. We have a section on when to do PET, and then once you've made the diagnosis, sort of moving towards surgery. So this document was available on our clinical homepage, so any provider could access it for guidance in terms of the workup for patients. And then we also, this was the best practice advisory, as I was mentioning. You can see it links at the bottom to a consult to cardiac surgery, so this would fire anytime it was placed in a hospital problem list. And then we changed our ID consult order so that endocarditis would show up as a box that people could click, and then we would also get alerted when that would happen. So it would allow us to try and track cases. I like to joke because it says endocarditis and then other. So there's like endocarditis is the only reason that you could check off for an ID consult. And so generally how we acquired our cases was through the ID consult service. In that initial study, we found that like 99% of the patients had ID consults, and the ones that didn't all passed away within 24 hours of admission. And then if there happened to be anybody that was missed, we would usually be able to catch that through the cardiac surgery consult service. One of the other things that we did, we'll talk a little bit, we had relatively lower numbers of injection drug use related endocarditis. It was about 15%, which is lower than a lot of other areas are seeing. But we did not have any kind of addiction consult service in our hospital. And so by this time I was an ID fellow, and so myself and one of my attendings, we got our DEA waivers so we could prescribe Suboxone. And we really worked with the inpatient psychiatry consult service. So they would see the patients inpatient and try to get them induced onto Suboxone. And then we could serve as a bridge in clinic until we could find them a more permanent outpatient option for prescribing Suboxone. So as I mentioned, June 2018, we started presenting cases. That first year, we presented 119 patients at our conference. And as I mentioned before, our in-hospital mortality for the definite endocarditis was 29.4%. And in our first year, we saw the overall mortality for those 119 patients fall to 7.6%. So we saw this really, fourfold essentially decrease in mortality. And then breaking that down a little bit further, about 2/3 of the patients we presented had definite endocarditis, and their mortality was approximately 5%. And then about the remaining third had possible endocarditis. About 10% had in-hospital mortality related to that. And then comparing the two groups sort of more specifically, so patients with definite endocarditis and surgical indications. So we had 68 in that first period, 56 in the 2018 to 2019 period. You can see that the mortality benefit was still preserved when looking at those specific populations, the decrease from 29.4 to 7.1%. We found that there was a trend towards increased proportion of patients getting surgery, so from 41 to 55.4. There was also the average time from admission to surgery decreased by 2.5 days. This was not statistically significant. And then we found that the average length of stay prior to a surgery consult really decreased dramatically from 7 days to 2 days. And we felt a lot of that had to do with the best practice advisory that we created. What you'll see here is that the outcomes for patients who were medically managed improved considerably as well between the two cohorts. So from 45% in-hospital mortality of the 68 patients down to 16%, and that was statistically significant. The outcomes for surgery were already pretty good, and so we did not have any in-hospital deaths in our surgical cohort in the period after the group was started. But you can see the mortality was already quite low, so it didn't end up being statistically significant. We also found that the number of surgeries for endocarditis increased by almost 50%. So the average of the 4 years before we started was about 36 cases a year. And in the first year of the group, 52 patients had surgery for active endocarditis. Just reviewing the microbiology briefly, it was pretty similar between the two cohorts. There was a slight trend towards more MSSA in the second group and a little bit more fungal endocarditis potentially in the first, but none of those ended up being statistically significant. And we tried to look at as many variables as we could to make sure we weren't missing any confounders. What you'll see here is that the initial cohort was about 7 years older on average. Some of the other differences, there was more acute renal failure in the first period, which obviously could contribute to higher mortality. But there were more cerebral emboli, and after we started the group, there were also more patients who were mechanically ventilated at the time of their evaluation for surgery. But as I mentioned here, you can see across the two periods, the amount of intravenous drug use was about 14%. So that stayed pretty constant and was relatively low compared to a lot of other pockets of the country. And what I'll say about that is our institution was fairly reluctant to accept these patients for transfer from other hospitals, particularly if they'd already had a valve replacement, because the culture historically at Michigan was that those patients would not be offered surgery. And so this was something that we were kind of fighting to try to get the patients here, but that was something that we struggled with the transfer center to work on. We did a regression analysis to try to identify, what are some predictors of in-hospital mortality. The only two that came out as significant were the presence of diabetes and then the year in which patients were admitted. So essentially, if you came in after the team was started, that was a predictor of you being more likely to survive your hospitalization. And then we did a propensity matched analysis to try to control as much as we could for the variation between the two groups, and essentially found that our in-hospital mortality benefit was preserved. It was actually a little more dramatic between the two groups. You'll see that the proportion of patients getting surgery, actually the gap was a little bit wider with the propensity match group, and then the time to surgery actually ended up being almost the same with the propensity matching. terms of how did we change care, so almost 85% of patients had some change in their management as a result of being presented at the conference. 62% had a change in their antibiotic plan. About 20%, a little over that, had a change in their surgical plan. So either they were not going to have surgery, and then that the plan was changed to do surgery, or the timing of the surgery changed as a result of the meeting. And then we also did a lot of recommending for additional imaging or follow-up. But you can see the vast majority of patients had some type of change in their plan. And ultimately, we were able to publish these outcomes in the Annals of Thoracic Surgery. This came out online last year and in print in January. And this was really, to my understanding, kind of the first publication in the US of the benefit of these endocarditis teams. And so the hope here was that we would be able to encourage other groups and other centers to try to start these teams. I should say a little bit more, about the workflow. So as I mentioned, we would get the patients from the ID consult service or the cardiac surgery consult service. And then typically I would make a brief PowerPoint presentation that would be sent out to all of the team members about 24 hours before the meeting, along with a list of the patients that were going to be presented. We would include the primary teams on the conference, any other pertinent consultants, so who maybe weren't on the team but might be relevant. So if a patient had cirrhosis or if they had a cancer diagnosis, we would try to include the hepatologist or oncologist. And then I would present the slides briefly at the meeting and try to moderate the discussion between the specialties. And then afterwards, we would write a brief note in the chart outlining kind of the medical decision-making and the recommendations of the group. And initially, we met in person. We continued doing this into 2020. And so after COVID started, we switched to Zoom meetings. And so I'd like to then share a case from of a patient that we managed at our endocarditis conference, about a year after we had started, and just gives you an example of the way that the endocarditis team was able to improve the care for an individual patient. And so this was a 71-year-old gentleman who presented to the hospital with fevers, just like the first patient that we presented. His medical history was a little more complex. He had 3-vessel CAD. He also had a history of NASH cirrhosis and prior hepatocellular cancer. There's medications. So he came in, and this was now October of 2019. So we've been a little over a year after we'd started our team. And he had fevers, was found to have strep salivarius bacteremia, initially had a TTE that did not demonstrate a vegetation, so was discharged with 2 weeks of IV antibiotics, and unfortunately came back with new cerebral emboli and was ultimately found to have mitral valve endocarditis. And so he was initially seen by one of our surgeons and was deemed too high risk for cardiac surgery, and so was not offered an operation. And then he unfortunately suffered another embolic event. He had an ST elevation MI, secondary to an embolization from his vegetation. And so he was discussed at endocarditis conference. We had 2 of our other surgeons there. We had hepatology there. And the discussion was that this patient, potentially, if he underwent a TIPS, could do well with cardiac surgery. And so he was referred and underwent a TIPS, and then was taken to the OR with a different surgeon, ended up having a very good result, and was still alive over 2 years later after this, after he came in for this episode of endocarditis. And so you can see how, now we had this kind of safety net for the patients where we could take them to the conference, try to get some multiple opinions. And so you didn't have one person's kind of fate being decided just based on who happened to be on service or the day that they came in. And then, the last part of the talk, I'd like to sort of focus a little bit on the research opportunities that these groups can offer. So obviously I mentioned the paper that we published with the overall outcomes. So that's kind of a big picture research project. But what we would find often is that we would present a case and it would be, we would have this interesting clinical question that would come up related to the case. And we'd do a little bit of a literature review, and there wasn't much out there. And so, we were able to start trying to answer some of these questions by keeping a registry of all our patients. One of the first things we did actually was we surveyed our physicians at Michigan to get a sense for what their perception of the team was. So we surveyed both not only cardiac surgeons, but cardiologists, hospitalists, infectious disease providers. We also included fellows and residents in this, and we were able to get over 100 responses, 126 in total. And what we found was that most people felt that the group was influencing the diagnostic approach, as well as the percentage of patients undergoing surgery, was influencing antibiotic selection, was helping to prevent management errors, decrease time to surgery, as well as decrease in hospital mortality. What was interesting was that some things that we didn't do as a group, people perceived that we did. So I don't think I highlighted this before, but our length of stay actually increased between the two cohorts from about 18 to 23 days, but providers felt like we were decreasing length of stay. And this was one of the things we were most proud of, was that people really felt the communication improved between the subspecialty teams, and that we really improved the documentation of the medical decision making. So now it felt like everybody understood the plan. It was clear in the chart what was going on. And so this was something that we were very proud of. Some of the other things that we tried to tackle, I know you and I have talked a little bit about this. So this question of F18-FDG PET and its role in diagnosing endocarditis, but then also just you make the diagnosis, but what about taking somebody to surgery based on the results of a PET? And so this was something that we ran into a few times, where patients who had prosthetic valve endocarditis, but the surgeons were a little bit reluctant to take the patients to the OR because on T, the valve looked okay. But clinically and based on the PET, this was a prosthetic valve that was infected, and it was unlikely to do well long-term with medical management. And so we were able to review the patients, essentially after we started having PET available, we reviewed all the patients who had valve surgery, and then went back and looked and saw how many had PETs. And we found 14 patients, so a fairly small series. But we looked at those cases, looked at all their PETs, and then looked at their operative findings. And what we found was that there were 14 patients that had PET. 12 of those PETs were read as positive, 2 were negative. All 12 patients that had positive PETs had some evidence of infection, either grossly in the OR, or their cultures were positive, their pathology was positive, or the PCR that we sent off of the valve was positive. And so we found that it really did correlate well with there being infection on the valve. And then we had 2 patients that had negative PETs, and then both of those patients ended up not having any evidence of infection intraoperatively. And so this ended up being very helpful at our institution. Maybe it hasn't changed management nationally, but we were able to share this data with the surgeons. And as a result, we were able to get more patients down the road access to surgery based on PET findings. I mentioned the PCR testing. Some of you may be familiar with this, but this is a 16S ribosomal RNA PCR testing that can be sent on patients who have endocarditis and undergo valve surgery. So you send it right off of the valve, and it can be helpful in patients who have culture negative endocarditis for determining what the etiologic organism is. And so we ended up looking at 41 patients that had valve PCR sent over a period of several years, and we're able to kind of look back and see how this changed management. And so what we found was about 44% of patients ended up having positive PCR results. One of the interesting things we found was that also 44% would get this test sent, and then nobody was reviewing it when it came back. And what we found as we looked at this was that the test would get sent out to the University of Washington, and then would get sent back about a week later, and it would get scanned into the chart. But the person who ordered the test would get no notification in their inbox that the results had occurred. So then nobody would think to go back and look at it. And so as a result of this data, we went back, we changed the way that this was reported so that it would show up in people's inboxes. And that way we would ensure that the results actually got reviewed. And you can see even with, a low percentage of the cases being reviewed, there was still over 10% of the time led to changes in management. And if you just looked at the 23 cases that were reviewed, it was, over 20%. And what we also found was, especially for patients who had culture negative possible endocarditis, over half of those patients would have a positive PCR. So that was the group that, moving forward, we really tried to hone in on in terms of who to send this test in. The most common organisms that we found that were positive ended up being strep species. I believe it was 9 or 10 of the 18 positive results ended up being strep, and which is sort of consistent with what we see clinically. Many of these will clear just after 1 dose of antibiotics. So if you get the blood cultures a little bit late, but the patient's been on oral therapy, you might miss that. I know that's a little ID heavy, but but we were also able to do cardiology related research. So the question that came up a lot was, for many of our patients was, do they need a coronary angiography before they go to the OR? And we had issues sometimes getting access to it. Patients did not get sort of these semi-elective caps on the weekends. And so we could see it lead to delays in care. So we actually went back and looked through the FTS database at all the patients who had surgery for any type of endocarditis, either active or chronic, over a 10-year period. And we found there were about 430 patients who did get a cap and 168 that didn't before going to surgery. Only 9% of patients ended up getting bypass, so a fairly small percentage overall. There was no difference in 30-day mortality for patients who had caps and didn't. And when we looked at sort of what the predictors were for finding coronary disease, it was all kind of the typical risk factors like older age, hypertension, diabetes, smoking history. So we used this to try to hone in a little bit on who really needs a cath, because we had, pretty much everybody was getting a cath at the time we started our group. And we started doing more, coronary CTAs that were a little bit less invasive and more readily available. We wrote kind of a review article on the management of endocarditis. And then we were also able to explore some other sort of novel antibiotic approaches. So this was a paper that we wrote looking at combination therapy for MSSA endocarditis and bacteremia. So and instead of just giving oxacillin or cefazolin monotherapy, we would add ertapenem. And we found that by doing that, we were able to rapidly clear blood cultures in patients who had otherwise been persistently positive. And since that was an indication for surgery, we were able to get more people to be managed successfully medically, and we had a 0% mortality at 90 days in the 10 patients that we studied. We were also able to look at partial oral antibiotic therapy, which there's been more data to support that, but not so much in patients who inject drugs. And that's been one of the criticisms and why a lot of ID providers have been reluctant to do it. And so we were able to just do a series of 11 patients where we managed them with oral therapy. And all those patients were able to complete treatment. We had no relapse with the primary organism. 10 of the 11 patients followed up in clinic. And so we were able to publish this just recently. We also created these heart valve infection prevention cards that we would give to all the patients either on discharge or at the time of their follow-up. So one of the things we found is that patients would go into, these are patients who have prosthetic valves or had endocarditis before. They would go in to see their PCP or their local ER with fevers or kind of chills, even night sweats. And they were being prescribed oral antibiotics, but nobody was getting blood cultures. And so, we tried to really educate the patients on how to advocate for themselves. We talked about what symptoms to look out for. Ask the patients to ask their doctor to get blood cultures. And on the reverse, we sort of made a side for providers with, the list of indications for prophylaxis, asking them to get blood cultures. And then we had our ID and cardiac surgery clinic phone numbers on there, so the providers could call. And we actually got a fair number of calls from patients, in their dentist's office or their primary care doctor's office. We did a sort of a webinar about how we managed the addiction treatment for our patients with endocarditis at our institution. And then had a kind of couple narrative pieces, just kind of highlighting the experience of getting this off the ground. This one called The Importance of Being Earnest, like the title of this talk. And then more recently, kind of a step-by-step guide to how to start an endocarditis team, just sort of based on our experience. So that way, for other people who are interested in maybe developing something like this at their institution, they have somewhat of a framework. So they don't have to kind of fly by the seat of their pants like we did. So obviously I'm not at the University of Michigan anymore. I'm now at the University of Kentucky, where we have, started an endocarditis team as of September of 2021. We have cardiac surgery, cardiology involvement. ACEs is our addiction consult service here. Infectious diseases, neurology, neurosurgery, pharmacy, social work. We meet Wednesdays from 4 to 5. Chandler is our main hospital, and so we discuss all of our inpatients admitted with endocarditis. We have a pretty significant volume here, anywhere from 10 to 15 patients a week that we're presenting, sometimes up to 20. And so as a result, we've actually started an ID consult service that just sees patients with endocarditis and cardiac device infections. And so that is staffed with an attending. We have some APP support, as well as a pharmacist and a nurse navigator. And we're interviewing right now for a social worker and an APP, so we can really round out our program. And we're letting students, residents, fellows rotate with us, so we can try to educate kind of the next group of providers. So I like to close a little bit with some of the lessons that I learned from this process. Throughout all this, I did most of this as a trainee, as a resident, as a fellow. And so sometimes it takes fresh faces to solve old problems. Our model of care had been the same for many years, and people had become so accustomed to its inefficiencies that they were sort of indifferent to change until we came in and looked at it a little bit differently, because we hadn't had that same long experience. Data is important. It can get your foot in the door, but it will only take you so far. And it was really speaking to people's humanity through that M&M that helped to gain more support for what we were trying to do. And we tried to identify common goals for all the stakeholders and create solutions around it. So, I think there can be a tendency sometimes with this to lay blame on, oh, well, it's the surgeons don't want to operate, or, ID is being too aggressive. But really, everybody wants the patients to do well. And so that was the focal point of what we were trying to do, was how do we get the best possible outcome for the patient? And when we framed it in that way, that was when I think we were able to develop more consensus. Have the courage to act without a guarantee of success. We started this and we didn't have funding for it. It was something that that all the people involved knew was going to be important and helpful for patients. And so everybody volunteered their time, which was really encouraging to see. I think every week when we would come and meet, just knowing that people were showing up consistently, they weren't getting paid to do this, but they came because they knew it was the right thing to do for the patients. And really, you have to try to stay grounded in what you're doing so that you can stand resilient against obstacles and setbacks, because we had those, but we really stayed grounded in our goal of trying to help patients. And ultimately, there's that hope that we could change things that became, the foundation of that change. And that's the point I really like to highlight, because I think sometimes it can feel hopeless when you're sitting there taking care of a patient who you think needs an operation, or you're watching them die, and there's nothing you can do. That can be a situation that feels pretty hopeless as a provider. But we really, hung on to that idea that with the right framework, the right teamwork, we could improve things, and we were able to do that. And that helped us persevere through a lot of the obstacles that we had. So obviously it was a team approach. There's a lot of people on here to thank. All these people contributed in some way to the meetings or to the data. And so with that, I'll wrap up. I'll open it up for any questions that people have, and if they'd like to email me, this is my UK email. You can feel free to shoot me an email with any questions.
Thank you so much, Dr. El-Dalati. That was amazing. And just hearing the talk, I thought of like three different things that we could look into, or thinking back to experiences we had. For example, like that patient you had who had a STEMI from embolic event from his mitral valve. I'm just thinking, like, how would we even treat that? With thrombolytics, obviously that seems like a bad idea. With the stent, maybe not. But even just that one case made me think about down the line what people done. But I see that we have a lot of different people on the talk. We have cardiology fellows, we have imaging attendings, we have interventional attendings, we have a good contingent from infectious diseases. So I just wanted to open it up and see if anyone had any questions for Dr. El-Dalati.
I have a question. Thank you for the talk. It was fantastic. I'm just curious about your experiences with in-person meetings versus Zoom, and whether you feel like Zoom made things maybe in some ways better because more people could attend, or if there's something valuable lost from being gathered in a room, just since it's such a pertinent thing for all of medicine's tending to move now to team-based approaches and having these meetings.
Yeah, that's a great question. So when we first started doing it, none of us were really as familiar with doing Zoom. This was in 2018 before COVID. Obviously, everybody's much more familiar. I thought it was really helpful for the group to meet in person initially because everybody kind of developed more personal relationships with each other. And so people who really didn't know each other before got to know each other, the ID providers, the surgeons, the cardiologists, neurologists. You're right, though, that the Zoom allows more people to attend. And I think probably like a hybrid model where you have a Zoom option for people to call in, but you also have an in-person meeting might be the best way to hit both of that. I have found, starting a new institution, we've been only doing this by Zoom. And I will say it's sometimes easier for people to have more conflict with each other on Zoom, especially if their cameras are off. And so I do think there's some value to trying to meet in person if you can, but obviously there's limitations in the world we live in now.
Dr. El-Dalati, this is Eric Yang from UCLA. Thank you for a fantastic presentation, and congratulations on all your efforts and work. And Yi, thank you as well for the invitation as well for doing this. I mean, endocarditis to me has always been a very, science-wise, a very fascinating field with so much heterogeneity. And like most things, I think, a multidisciplinary approach ultimately for most things creates better outcomes. I had a question probably more culturally based on your time in Michigan. And I'm just kind of comparing it here. And also I don't know if you know this, but you're talking to 4 different clinical sites here. We have, our Ronald Reagan Tertiary Center, Community Center, Santa Monica, VA, and also Olive County, LA County. So we all have a bit of, we all have some different cultures and referrals and team-based approaches. At Michigan, how often was cardiology itself involved in endocarditis care? I know you mentioned mainly ID and CT surgery, but I feel like sometimes for cardiology services, if it's not on a cardiology consult service, at Ronald Reagan, we're pretty routinely involved, mainly for several reasons. One, because if they're outside transfers or referrals, we kind of act as a clinical bridge between ID and CT surgery. I mean, we go through like imaging. We sometimes frankly see things that the outside didn't catch, or they misdiagnosed, or we kind of basically act as the interpreter of how to approach disease or how to deal with, clinical issues, and I was wondering in Michigan, how often were cardiology consult services involved in 100% of these cases, or in some form or another, or was it just mainly kind of medicine, ID, and CT surgery?
Yeah, that's a great question. So it was about 60% of the patients would actually be admitted to a cardiology service. So it was about 65% of our patients were transfers from other hospitals. And some, like you were alluding to, most of the transfers would come to cardiology service, and they would be the primary team trying to coordinate between the different subspecialists. If they were not on a primary cardiology service, then the consult involvement was variable. If they needed if there was a question about a cath, then usually their consult team would be involved. For TEE, typically the teams would just order the TEE, and there wasn't necessarily a consult. Same with PET. And so, but I would say probably 75 to 80% of the patients had some type of cardiology involvement, either from the primary team or as a consultant.
Yeah, because I don't, again, I personally have not asked or polled my ID colleagues about this, but usually cardiology and CT surgery, usually for us, we would talk very in depth to each other about, well, what do you think about this? Yeah. And we provide sort of the anatomic information that we think we see and what else could be dealt with, and I know ID focuses a lot about the microbiome and as well as the extent, and obviously other metrics that are very important for duration of therapy and diagnosis and workup. But, I don't know if at all centers, all three are always involved. And my personal opinion is that they all should be involved to be able to, provide more nuance and perspective. But obviously in this heart team approach is really critical, I think, from that standpoint. But I can see sometimes when there's no cardiology sort of oversight on top of that. And I'm not just, promoting our own field, but I do feel that sometimes we can talk between the two fields and talk about kind of what are some of the issues at hand here, so. Yeah. But usually we're asked to take a second look at outside imaging, outside workup, and give our thoughts about it as well. So I'd be interested to hear all the other thoughts in the audience of what they say or what they think.
Yeah, this is Jesse Currier. I think, any time I can attend a Zoom conference and have my wife be on the same call, that's pretty exciting for me. My wife is chief of ID at UCLA, so this is a topic near and dear to our hearts. Thank you for inspiring Yi and for giving this great talk. Yi has tried to set this up at the VA, where fortunately we already have a pretty robust heart team approach for complicated patients. And so we've tacked on an endocarditis portion. We don't quite have the volume to do it on a weekly basis, but it's been a great addition. I think one of the things that's probably been the most well received from our informal polling is precisely what Eric was just talking about, is if cardiology doesn't happen to be involved, I think it puts the primary team in an incredibly difficult position trying to get, a consensus of opinion between two services that rarely seem to interact person to person, that being CT surgery and infectious diseases. So I think it's a little easier with cardiology when the patient's on a cardiology service, but certainly if you're on the MICU service or on a cardiology ward team, I think it's really tough on the primary care. And the people that I've spoken to, they're the ones who sort of love this part of the conference, as well as the ID colleagues, although they have a competing conference today here at the VA. And most of them have been very upbeat about it and have really enjoyed it. And I certainly learned a lot, much as we do. We have a PFO conference with our stroke neuro colleagues. We have a nuclear conference with our nuclear colleagues for these complicated patients. And this has just been another layer of multidisciplinary care that's been really, really educational and I think productive for us. So thank you.
Yeah, absolutely. Thank you for the comments and questions. I definitely agree that understanding the culture is super important. And we always had 1 to 2 cardiologists at all the meetings, even if we didn't have the consult service following or they weren't on a primary cardiology team. So there was always some type of cardiology input. Sometimes, and probably more so at UK, we get a little more pushback. The consult services have a lot of patient volume, and we have a lot of endocarditis, and so sometimes they're not as thrilled about seeing the patients, but we do always have somebody on the meeting who can look at the echoes with us, or we communicate. One of the really great things about this is then people who don't really, like you were alluding to, don't normally talk to each other, start talking to each other. So now if I have somebody I'm seeing and I want another opinion on the echo, I can just text one of my colleagues and say, hey, do you mind taking a look at this echo? And then we'll call and talk about it. And so that's another great advantage of this, is you build these relationships and then you can have communication outside of the meeting that will still benefit the patients.
Hi, this is Judy Currier from UCLA, the wife of the former speaker. I think this is really terrific, and it was really great to see that you have the addiction medicine as a part of your team. Are you seeing that by including them and addressing the addiction issues in people in the hospital, that you're making progress and potentially getting them effective therapy when it's indicated?
Definitely. So I just have to speak more to my time at UK because we didn't have a ton of patients at Michigan. We did find after we started sort of that ad hoc approach that we were able to get more people connected to treatment. But things right now at Kentucky we've really been able to get our patients access to medication-assisted treatment for their opioid use disorder. Virtually everybody gets started on either Suboxone or methadone prior to discharge. And we're fortunate that we have some grant funding through our ID division to help our patients with substance use disorder with case management. So we can help them with transportation, not just to ID appointments, but also to cardiology, cardiac surgery follow-up, or their addiction follow-up. And so we've really seen our follow-up improve since we started this in September. I don't have the raw numbers yet, but from what I was told before I started, that our follow-up rates were about 25%, and I would say we're probably more up around like 75-80% now of our patients that are following up. And I think the addiction team is a huge part of that. And we actually do some weekly case management meetings with them outside of the conference so that we're all on the same page with, where's the patient going? What's their MAT going to be? Where are they going to get it? Are they going to get it from me, an ID clinic, or are they going to get it somewhere else? So they've been a huge part of the success, at least here.
Well, I know it's 1:06, so unless anyone has any other pressing questions, we have Dr. El-Dalati's email. If you have any additional questions, or feel free to send to me, I can ask him on your behalf. Again, thank you so much, Dr. El-Dalati, for this amazing talk, and thank you everyone for joining in. I'm excited to see what other work comes out of your teams.
Yeah, I was also joking with Yi and Nagin offline about this, but as an echocardiographer, this is your opportunity to show off these amazing images. I feel like the Duke criteria really undersells how incredible now with echo technology, with TE and 3D now. There's some really ridiculous, amazing stuff that people can show, like of pathology. And I think that gives the surgeons a lot more anatomical, and and this is, I'm just being stereotypical because I love ID itself. I almost thought about ID as a career, but like, you guys see a lot of more of the bugs and the radiographic stuff of things, but like imaging adds a whole new element now of like really where everything is. And whenever ID comes by around the echo lab, we get really excited. We're like, oh yeah, you got to check this out. It's ridiculous. Like, look at this crazy, like, mass and what it's doing and stuff. So I think that also helps the enthusiasm of the field too, from that standpoint. So.
Well, thank you. I really appreciate the opportunity. Thank you, Yi, for inviting me, and thank you everybody for coming and for your questions. And yeah, if you do have any questions, please feel free to shoot me an email.
Thanks, Sami.
Thank you.
All right, thanks.